Dr. Dr. Harpreet Singh and today's chairperson, Dr. M.K. Senapati. I have seen all of them. Dr. Senapati, please unmute yourself. Good evening, Dr. Senapati. Hello.
Hello.
Oh, good evening, Mukti. Good evening, Dr. Senapati.
How are you, Dr. Senapati?
Yeah, I'm fine.
Very good to see you.
Seen you for a long time.
Good evening, Kalyan sir, Ranjan Day sir, Senapati sir, and all
Yes, Harpreet. Nice to see you.
Yes, sir. Same here, sir.
And happy Hindu Navvarsh to all of you.
Thank you, sir.
Yes. Is Hindu Navavas. Yeah. And the I will have to just hand over the session to Dr. M.K. Senapati sir. I must mention today's teacher is Dr. Nitesh Kumar. Dr. Harpreet Singh will be the moderator. Dr. M.K. Senapati is the chairperson. Dr. Nitesh Kumar, Dr. Supriya Basu will be in the chair. And our beloved students are Dr. Dipankar Bera. Dipankar, please introduce yourself. Dipankar, introduce yourself.
Sir, I am Dr. Dipankar Bera from NRS Medical
We
College.
cannot hear you. Your voice is poor.
Hello. Can
Yes.
you hear me, sir? Hello.
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 Dipankar, introduce yourself.
Sir, can you hear me, sir? Hello.
Yes, get a bit close to your mic. Your voice is a bit soft.
Sir, I am Dr. Dipankar Bera from NRS Medical College and Hospital, sir.
Okay. He is from NRS Medical College, Calcutta, and most likely the student of Dr. P.K. Mondal. Dr. Ankit Sadhu.
Yes, sir. Myself, Ankit Sandhu, sir. I am from IPGMR and SSM Hospital, sir.
IPGMR from Professor D.K. Paul. And
Voice
Dr.
is breaking
Pare.
in between.
Yes, sir. Good evening, sir.
Good evening. You are from?
Sir, IPGMR, Kolkata, sir.
All of you from Calcutta today. Fantastic. So, welcome all of you. With
Thank
this
you.
introduction, it is just 7 o'clock and we should start the session right in time. I will hand it over to Professor Dr. M.K. Senapati for conduction. Before that, I will request our President, Dr. Kalyan Kumar Sarkar, to few words regarding today's program.
Thank you, Dr. Ranjan. Very good evening to all of you. So it's my pleasant duty to say hello to all of you and welcome you all to the second online class. This is the first year of such a venture in East Zone. And it will succeed only with strong participation of all the members, all the teachers, chairpersons, moderators, and of course the students. So may I now ask the chairperson to please take over the proceedings.
Yes, sir. Nice to see you, sir.
Nice to see you too.
Yeah, in today's session, I would like to introduce the teachers like Dr. Nitesh Kumar, Dr. Supriya Basu, and the moderator is Dr. Harpreet. He will moderate this session, and already the students has been introduced by them. So let's start the session. The topic well known about urinary stone disease with metabolic evaluation, and there is a video also. So let's start the session so that we can finish it in time.
Thank you, Senapati, sir. Thank you, Senapati, sir.
Please moderate.
Good evening, President, sir, Kalyan Sarkar, sir, our Honorary Secretary, Dr. Ranjan Day, sir, and our Chairman today, Dr. Senapati, sir, and my fellow colleagues, Nitesh and Supriya, sir, and all the students. I thank, first of all, East Zone leadership for framing such a nice program. And I think it's the first time in our zone we are having such a elaborate and planned is covering theoretical topics as well as the practical topics. So I thank you, Dr. Sakar and Dr. Dave for giving me this opportunity. I will not waste time. I'm very happy that we started 2 minutes before time. So I will straight away invite Dr. Dipankar Bera to present his presentation on metabolic evaluation in stone disease. Dr. Dipankar, over to you. I request everyone to mute their speakers.
Sir, good evening. I will present the PowerPoint presentation on metabolic evaluation of stone disease.
Yes, you start your presentation.
Yes, sir. I'm sharing the screen. Sir, can you see the screen, sir?
Yes, yes,
Yeah,
I can
yeah,
see
we can
your
see the
slide.
screen. Dipankar, carry on. Make it full screen, Dipankar. Make it full screen.
Yes, yes, sir. Is it okay, sir?
Not yet, Dipankar.
Can you see the screen, sir?
Yeah, but not full screen,
Yeah,
not in the
yes.
PPT mode. Make it on the presentation mode. Yeah, make it slideshow. बोलो तुम मेरे को MCQ वाला तुम्हारा आया नहीं पर तुम ही प्रेजेंट करना उधर से ठीक ना मैंने कोई 10-12 क्वेश्चन बना दिए हैं ठीक है
Sir, can you see the screen?
Dipankar,
Yes, sir.
it's not in the presentation mode yet. Can you make it full screen?
Sir, when I'm trying to make it full screen, getting spoiled.
No, no, it will not pause. Just go below and make it a full screen. It will be
Slideshow.
Chalo. Okay. Go ahead. Start.
Sir, so the goals of the evaluation are to prevent recurrent stone formation in high-risk patients and
move your slide. Your slide is same on the metabolic evaluation. You are now speaking on second slide. Presentation is not moving, Dipankar. Your goals is next slide. So just I'm make it a presentation mode. Okay, yeah, better. Go ahead.
so the goals are to prevent recurrent stone formation in high-risk stone producers and to prevent further growth of any existing stones and to correct any underlying physiological disturbances that may lead to non-recurrent complications. So these are the goals. And so what should be the characteristic of the test, the metabolic evaluation the test? The test should be simple to perform and they should be economically viable and they should provide information that can be applied to a selective and rational therapy for stone. Now, selection of the patients. For the first time stone formers, we know that there is 50% risk of recurrence within the subsequent 10 years. So, we will select metabolic evaluation even for the first time stone formers and the formation of stone. Maybe the harbinger of a more severe underlying stone disorder like renal acidosis or bone disease or hyperparathyroidism. In such patients, metabolic evaluation is justified to correct diagnosis to prevent external complications. The decision of to thoroughly investigate the first time stone former, it should be ideally shared with the physician by the physician to the patient. So we'll state the patient that these states are available, and if he agrees, then we can go for the metabolic evaluation in first time stone formers. So what is the timing? Says that at least 1 month after the stone passage or removal of the stone, and allowing the patient to return to their normal visit. So these are the indications of stone evaluation, and these are the high risk stone formers that we will go for metabolic evaluation. First, the recurrent stone formers, and if the patient is having a strong family history of stones and any intestinal diseases, particularly chronic diarrhea, like inflammatory bowel disease and the Crohn's disease, ulcerative colitis. In these patients, we have to go for stone inhibition, metabolic inhibition. And in patients with pathological skeletal fracture, osteoporosis, or if the patient is having urinary tract infection along with the calculi, and if is any personal history of gout or in some anatomical abnormalities like the horseshoe kidney, the solitary kidney, in these patients we have to go for stone inhibition. And some particular stone types require stone inhibition like the cystine stone, the uric acid stone, and the screwbite stones. And for pediatric population, all the children should be evaluated by this metabolic evaluation because they are the high risk patients for stone formation. So this is the applicated protocol for low risk single stone formers. And there will be history and physical examination. And among the history, the diet history is very important. And the pattern of fluid intake for the patient, we have to enter in the history. And if there is any underlying predisposing conditions, as already said, and medications like calcium, vitamin C, acetazolamide, steroid, and already said that if there is any inadequate fluid intake, the occupation of the patient we have to ask about. If it involves any hot humid climate environment, then the patient is at risk of stone formation due to dehydration. And after the history, we have to go for the multi-channel blood screen, the basic metabolic panel. Those are the electrolytes like sodium, potassium, chloride, the bicarbonate, blood nitrogen, and creatinine. And also the serum calcium, intact parathyroid, and the uric acid. And we have to go for a basic urinary disease to look at the pH and volume of urine and any crystals if we found that can guide us to the type of stone. And also we will go for urine culture to look for the infection urinary tests. Infection data like urea splitting organisms we have to look for. And the radiography of the stone we have to do, and finally the stone analysis if the stone is available. So these are the various types of crystals. You can see during urinalysis, like the hexagonal crystals in case of 16 stones, and this is the calcium oxalate modified that it envelopes if it's the crystal can found, and this is the calcium oxalate trihydrate stone showing the hourglass configuration. So the type of crystal we found in urinalysis that can guide us towards which type of stone we deal with. Now the metabolic equation for high risk and recurrent stone formers. The previously was the first time stone formers. Now we are talking about the high risk patient and recurrent stone formers. So we have to do some additional testing apart from the basic metabolic panel. Like the 24-hour urine analysis. At least one or two urine analysis we have to do while the patient is on a random diet, and this urine 24-hour urine should be analyzed for total volume, the pH, the calcium, oxalate, uric acid, citrate, sodium, potassium, and creatinine. Apart from the 24-hour urine analysis, there is one fast and calcium load study, but this test is not widely available and also not practiced later. So how to collect the 24-hour urine? We have to make the patient understand how to collect the urine. So the patient will choose a day when all voids can be completely captured and when the specimen is represented typically. And this will start from we have to discard the first morning void, and after that all the voids throughout the day will collect, and up to the next morning void. The first morning void of the next day will be collected along with the rest of the specimen, and there will be completing the 24 hours. and the total event rating should be measured to provide an internal check. Before and throughout the period of evaluation, the patient is instructed to discontinue any medication known to interfere with the metabolism, calcium, acid, or oxalate. Any current medication or stone treatment that should be discontinued as well. And it is said that 2 random 24 samples are collected, but we can go single. And these 24 samples are obtained with the patient on a random time.
Requesting everyone to mute yourself. Please mute.
The patient who maintained either her normal diet and presented during the collection. Now, coming to the stone analysis, if the stones are available, then we have to send it for analysis. And if stone analysis should be performed if the stone formation continues, particularly they are not responding to treatment. There are maybe two methods of stone analysis. First is the X-ray diffraction, and the next is the Fourier transform infrared.
Ruma, please unmute everybody excepting the speaker and the moderator, please.
So we are talking about the two most widely recommended and utilized methods, the X-ray diffraction and the Fourier transformation infrared spectroscopy. But there is some limitation with these two methods, like these are destructive methods, and they rely on turning the stone into powder before analysis. So once the stone is destroyed, the opportunity to evaluate the microstructure and different compositions is lost. So there is one another emerging technique, the micro-CT, which is a non-destructive technique where small structures such as stones can be visualized with 1,000 times the resolution of clinical CT scanners. So, thank you, sir. These are the tests we are doing for metabolic evaluation. Thank you.
Thank you, Dipankar, presenting in brief and almost covering everything and in a very in your given time. I will please unshare your stop sharing, Dipankar, so that we can see each other. Senapati sir, we will take the questions at the end after all the presentation.
Yeah, yes.
Okay. So I will invite the next speaker then. Ankit is the next speaker.
Yes, sir.
Stone disease in pregnancy. Go ahead, Ankit.
Yes.
Ankit Sandhu.
Yes, sir. So screen, he has not stopped sharing the screen.
Ankar, please stop sharing your screen.
Yes, sir.
अंकित आप अपना स्क्रीन को फुल स्क्रीन कीजिएगा, चेंज करना इजी होगा आपके लिए. Yeah, share your screen. I will request everyone to keep yourself muted. If you are not a speaker, please keep yourself muted. I'm very happy to see at least 40 participants are there. So good. Great. Ankit, you can begin.
Yes, sir. Thank you, sir. Today, my topic of presentation is urolithiasis in pregnancy. Epidemiology, most frequent and complex urological consultation during pregnancy. Incidence is 1:200 to 1:1500 pregnancy. Renal colic secondary to kidney stone is the leading non-obstetric cause for hospitalization in the pregnant woman. It increases the risk for preterm delivery, preeclampsia, placenta previa, and premature rupture of membranes. Multiparous women are reported to be acutely affected more often than parous women, ratio of about 3:1. A strong relationship has been found between prior pregnancy and subsequent episodes of nephrolithiasis. Despite the predominance of right-sided hydronephrosis, there is a similar incidence of left and right symptomatic calculi. Most patients with symptomatic calculi present during the second or third trimester. Now, the physiological changes that occurs during pregnancy, there is a significant dilatation of the pelvic lysis system and ureterus occurs during pregnancy, followed by 6 to 10 weeks of gestation. Progesterone increases smooth muscle relaxation and reduces peristalsis in the ureter. The enlarging gravid uterus compresses the ureter, especially later in pregnancy. Physiological hydronephrosis occurs in 90% of pregnant women by third trimester, may persist up to 12 weeks postpartum, and pelvic axial dilation up to 2 cm can be regarded as normal in pregnancy. The right sided is generally more dilated than left, possibly as a result of dextral rotation of the uterus and the protective effect of sigmoid colon over the left ureter. Now there is 30 to 50% increase in GFR. There is increased filter loads of sodium, calcium, uric acid, resulting in a state of hypercalciuria and hyperuricosuriia. There is suppression of parathyroid hormone because there is increase in circulating 125 dihydroxycholecalciferol production by the placenta. 24-hour urine chemistry show urine pH is elevated most dramatically during the second trimester. There is increase in the excretion of urinary inhibitors such as citrate and magnesium, and there is increase in urine output. The most common stones are calcium stones that account for about 80% of stones in the general population and also the most common stones found in pregnancy. Up to 74% of pregnant patients with kidney stones have calcium phosphate stones in contrast to general population where calcium oxalate is more common. This is thought to be secondary to renal excretory changes and higher pH of the urine in pregnancy. Now, evaluation. Usual manifesting signs and symptoms may be masked by the patient's gravid uterus. 28% of pregnant patients incorrectly diagnosed with appendicitis, diverticulitis, or placental abruption. Symptoms are usually flank pain, macroscopic or microscopic hematuria, or UTI, which may be recurrent. Urine analysis, district analysis of midstream specimen of urine can be done, and alkaline pH more than 7 suggests infection with the urine-splitting organism, and less than 5 may be associated with a uric acid stone. If the district is positive for nitrates, a urine culture and sensitivity should be sent. Pyuria may be present at baseline, which diminishes the sensitivity of this parameter for detecting UTI. A diagnosis of urine calculus should be considered in evaluation of a pregnant patient who suffers from persistent infection with a urine-splitting organism. And a multidisciplinary approach is strongly recommended with involvement of obstetrician, maternal-fetal medicine, physician, anesthesiologist, pharmacist, and urologist in collaboration to develop a safe and effective plan for the patient. Now, the effect of irradiation on the fetus can be categorized into teratogenesis, carcinogenesis, and mutagenesis. High dose of radiation before implantation and first 2 weeks post-conception may lead to fetal loss. Exposure at around 4 to 10 weeks may suscept the patient to the teratogenic effects. At 8 to 15 weeks, dose of 20 centigram may lead to mental retardation. And risk is increased with increasing dose at 40 and 60% at doses of 100 and 150 centigram. Risk of cancer and genetic mutation also increase with increasing dose. Dose of less than 5 centigram do not cause intrauterine growth retardation or other fetal anomalies. And most uroradiography studies can be modified to be performed within 5 centigram. Ultrasonography is a standard initial study in evaluation of the pregnant patient with suspected renal colic. They should be used prudently and only when use is expected to answer relevant clinical question or otherwise provide medical benefit to the patient. Sensitivity of only 34% with a specificity of 86% is found. Disadvantages of ultrasonography are that it is operator dependent and it can be exceptionally difficult to adequately visualize the ureter or distinguish physiological hydronephrosis of pregnancy from ureteral obstruction because of a calculus. Transvaginal ultrasound is good for imaging of the distal ureter. Now, Doppler ultrasound should be employed with caution as ureteral jets are unpredictable. It is used to calculate the renal vascular resistance. Renal resistive index remains unchanged from the non-pregnant state throughout the course of pregnancy and is also unaffected by the physiological hydronephrosis of pregnancy. Operational use of resistive index had 45% sensitivity and 91% specificity in detecting an obstructive ureter calculus. A change in RI had a 95% sensitivity and 100% specificity. MRI provides detailed and cross-sectional images and has addition of no ionizing radiation. The calculate do not have a distinct appearance on the MRI. Stone, clot, or other intraureteral lesions appear as a filling defect on T2 images. One double king sign, where a standing column of fluid to the pelvic brim and a second column of fluid from the brim to the presumed distal ureteral obstruction may suggest a distal ureteric stone. It is useful adjunctive study in the evaluation of pregnant women who have an abdominal pain. It accurately differentiates physiological hydronephrosis of pregnancy from hydronephrosis resulting from obstructive calculus. Half Fourier aqueous single short purpose MI protocol is increasingly used in the pregnancy. Others we can use IV rarely, that is intravenous pyelogram and nuclear urinography. Latest is a low dose CT, where utilization low dose radiation exposure CT has emerged as a technique of high utility and a low risk for pregnant patient and fetus. A positive predictive value of 95% for urolithiasis has been found. Current AUA guidelines suggest if ionizing radiation is necessary for diagnostic or treatment purpose, the radiologist along with obstetrician can estimate radiation exposure so that the total pregnancy exposure does not exceed the ACOG recommended maximum of 50 milligauss. According to AU 2022 guidelines, they recommended to use ultrasound as a preferred method of imaging a pregnant woman, followed by MRI as a second line, and low dose CT should be used as the last option in the pregnant woman. Now, the treatment is based on the renal function, size, location, and duration of pregnancy. Initial therapy, a period of observation in patients whose symptoms are controlled, can be taken because spontaneous passage of stones of about 50 to 80% will pass their stones spontaneously when treated conservatively with hydration and analgesia. Close follow-up for recurrent or persistent symptoms and management of pain may require small dose of administration of morphine, and NSAIDs are contraindicated due to risk for fetal pulmonary hypertension and premature closure of the ductus arteriosus if administered in the third trimester. Medical expulsive therapy with alpha blockers or calcium channel blocker, preferably alpha blocker, is advised. It facilitates stone passage by promoting relaxation of ureteric smooth muscle in non-pregnant population. AUA reports that should MET be considered for the pregnant patient, counseling should be done that MET has not been adequately investigated in pregnant population and the pharmacological agents are being used for an off-label purpose. Now, when we need to do intervention, when trial of observation fails in pregnant patients, when pregnant patients should be offered intervention. Intervention is required in approximately 1/3 of patients, usually for pain uncontrolled by analgesia or signs of persistent obstruction and infection. Surgical management, other indications are like infection, pyelonephrosis, obstruction, or intractable pain, nausea, or vomiting. Selection of the appropriate intervention depends upon the capabilities and limitations of the institution, wishes of the patient, and the clinical judgment of the urologist, obstetrician, and anesthesiologist. Ureteral stents are optimal treatment. They effectively drain and obstruct the collecting system. Recommended ureteral stent exchange in pregnant patient every 4 to 6 weeks due to increased incrustation of the stents. Complication, they may cause for increased risk for bacteria, UTI, and stent migration, accelerated incrustation of ureteral stents due to hypercalciuria and hyperuricosauria. And they may cause pain which negative effect on a patient's quality of life. Limitations are that they are not always easy to place. They cause bladder irritation, risk of displacement is there. They may cause vesicorenal reflex, which lead to lower back pain or acute pyelonephritis. Now, percutaneous nephrostomy is done for pregnant patients with obstructive renal calculi where DJ stents fail. Complications are incrustation and colonizing, pain dislodgement, and need for multiple interventions. They require exchange of tube because of occlusion from debris, fever, or pain. Definitive treatment pregnant patient, if required, can be done in second trimester. Systematic review overall complication rates of 8.3% with no significant difference in rates of urinary tract complications compared with the non-pregnant population. A multicenter trial reported a complication rate of only 4%. Stone-free rates are about 70 to 100%. Floppy tip guide wire is passed into the uterine orifice and under direct vision. The calculus is extracted with a Dormia basket. If it needs fragmentation, pneumatic and laser lithotripsys can be used without risk. Electrohydraulic shock is not advised because it has a risk of inducing labor. Ultrasonic lithotripsys risk for the damaging fetal auditory system. Shockwave lithotripsy is an absolute contraindication in pregnancy, but if SW has occurred in an unrecognized pregnancy, it's been said no need for routine termination of pregnancy is advised. Now, strategies to reduce or eliminate radiation exposure requires use of low dose or pulse fluoroscopy with collimation to minimize scatter, lead shielding of the pelvis placed below the patient, direct visualization without fluoroscopy, employment of intraoperative ultrasound guidance. Highly invasive therapies such as percutaneous nephrolithotomy should be deferred until after delivery because this procedure often requires prolonged anesthesia and radiation exposure. So, in summary, when if patient presents with hematuria, renocolic, pyelonephritis, we do a renal ultrasound. If a mass, then we go for MRI. If hydronephrosis, we should go for color Doppler ultrasound with resistive index. If stone is visualized, we can stent with ultrasound guidance. Or if stone not visualized, we can go for transvaginal ultrasound. If stone is visualized, we have options of stent placement, and if needed obstruction infection, we can go for retroscopic clearance. If stone not visualized, we can keep the patient on follow-up. Thank you.
Excellent presentation, Ankit. Very good, very precise.
I agree with, stop sharing, Ankit.
Yes, sir.
I agree with Ranjan sir. Very well, very comprehensive and very well covered.
Very nice
Right.
presentation, especially on pregnancy, with so much.
Very
controversy.
precise presentation. It
Very
helped us
nice.
also.
May I invite the next speaker, complication of stone surgery, Dr. Ishans Khare.
Yes, sir.
Dipankar, there is a question for you in the chat box. You can answer it.
Yes, sir.
Keep on seeing the chat box and you can answer the question so we can save some time.
So you can see my screen.
Yeah, it's just coming up. Yes. Still not there, Ishans?
I think Harpreet to continue. Then at last we can go for question answer session. Unnecessarily.
Sir, last question answer is there in the MCQs. So what we are doing is that anybody has specific question to speakers, so they can put in the chat box. I can always ask also at the last so that we save some time. So
Okay.
yeah, make it full screen. Ishans, make it full screen.
Hello.
Yeah, we can
Yes,
see your presentation, but can you make it a full screen?
So it is
There's
a full
option
screen.
there for making it full screen.
So I have already made it a full screen.
No, we don't see as a full screen.
Sir, I will again, sir.
Yes. Click on it.
Yes.
Then
Bottom right.
now it is visible full screen.
So may I start?
Yes.
Good evening, respected teachers.
not
Myself,
full screen,
Shash
yes.
Khare, and I'll be speaking on the topic complications of the stone surgery. Now, the complications may be divided into endocrinological and open surgeries. The various endocrinological procedures are URSL, PCNL, RARS, ECIRS, PUCLT,
Your slides are
PCCLT.
not moving. Dr. Khare, I'm sorry interrupting you. You are still on the first slide on the title slide.
So is it moving?
This is only first slide. Please move your slides.
Click on the next slide. It will be all right.
So is it moving? So
No. It's
No,
not.
no.
You're not able to make it full screen. Okay, so that's the problem.
So actually in my computer it is showing, but I cannot.
Anyway, go to the next
Move from
slide.
the side. Move it from the side, but slide sorter bar. You can move from there to seconds.
So may I again repeat, share it? I will
Yeah,
again
you can do
share.
it.
Yeah, no problem.
Harpreet sir, you have a fantastic participation.
Yes, sir. Very glad to see so many people logged in. I see Rahul, I see Ashu, Somrendra.
So now you can see, sir.
Is same.
So now it is changing.
No.
No, it's
No,
not
same
changing.
first slide.
Double click to enter the full screen.
Yeah, double click.
presentation.
Exactly. Double click it.
Yeah.
Now
it's
it's
changing.
moving.
Now it is.
So actually on full screen, it is not just moving, just hanging
Yeah,
out.
full screen we are not
Okay.
showing.
Very. Go back.
No, sir.
Start
The
from the
first,
second screen. I see Dr. Rajesh Tiwari, Shashank Barua. So good, very good attendance today.
Very good moderator, very good attendance. Don't worry.
It's early to pull my leg on the Saturday evening. He's still not high of it.
Because I cannot offer you anything better.
sir, I'll continue with this.
Yeah, please continue.
Continue.
Continue, sir. Continue.
Now, first of all, sir, complication due to analogical procedures, which include namely URSL, PCNL, RARS, ECIRS, PUCLT, PCCLT, cystoscopy, and cystotholopexy. Second group comprises of open surgical procedures, which includes open renal stone surgery and open bladder stone surgery. It may be classified broadly into three categories: intraoperative, early postoperative, and late postoperative. Now, intraoperative complications include first urethral bleeding. It may be dilatation due to urethral access sheath, misfired energy, or due to mucosal injury. These are limited, and if bleeding is severe, we can abandon procedure and place a resistant. Second includes the low-grade urethral injuries. They present as a contusion with Volpetaceae, superficial mucosal erosions, and false spaces. The various etiologies are during the guide wire placement, scope manipulation, misfired energy, instrumental deployment, and stone removal. What we have to keep in mind? If the injury have occurred, the procedure can still be completed with extra care not to convert a mucosal erosion to a perforation, and the site of the injury should not be crossed repeatedly. At the conclusion of the procedure, we must place a degestant. And if we suspect a high-risk injury, we should abandon procedure and put a urethral stent. The third includes the high-grade urethral injuries. These include perforation, intussusception, and avulsion. The etiologies are scope manipulation, misfired energy, instrumental deployment, and trapped stone removal with excessive force. First, the perforation. These are more common in the mid-urethric location. However, the rate is similar with or without the use of urethral access sheath. If this complication occurs, we should abort the procedure and place a urethral stent. The second one is intussusception. It mainly occurs when a mucosa telecops inward, folding on itself and separates from the underlying stroma. It is common during the basket removal of the trapped large stone. So blind basket removal should not be done. Third is the avulsion. It is the most feared complication. It most commonly occurs at the PUJ or at the proximal ureter. It may occur due to the removal of large and trapped stone with basket with excessive force. Now, what is escapade effect? It is when the proximal scope becomes wedged in the narrow distal ureter, resulting in the friction and dissociation of the mucosa. It can also be seen when small fragments get trapped along the length of the scope. What is the management? We have to do urgent piece insertion and we have to defer the further treatment. And it depends on the location of the injury. And the various surgeries include ureteroneocystostomy, psoas, Boris flap, eyelid restitution, and autotransplantation, depending on the site of the injury. The fourth one is the failure and conversion. Failure is defined as the inability to access the ureter during the initial treatment. Management will be, if we can see the ureteric opening, it is narrow, we can put a degestant for 2 weeks and then part for the definitive treatment. It is more common in the proximal location than a distal. The fifth one is the instrumental failure. It may be due to stone retrieval basket failure or a scope damage. Second group is the early postoperative complications. These include bleeding, which can be managed by the observation or simply placing a urethral stent. Second is the bladder span, mainly treated by anticholinergics. Post-op fever, UTI, sepsis, it can be controlled by the antimicrobials as well as with the fluid management. Late postoperative complications include urethral stricture. It may be due to difficulty during guide wire placement, scope manipulation, misfired energy, instrumental deployment, and stone removal and impacted stone. Management includes post-op imaging followed by the endoscopic dilatation or incision or open or laparoscopic repair. Second is the retained and encrusted urethral stent. This complication occurs mainly due to non-compliance of the patient, and the management includes to do a radiological study in the form of CT scan to document the degree of the stone burden at the proximal and distal curl. Distal curl should be addressed by the cystoscopy, tripsy or pexy, and proximal curl we may need URS as well as PCNL. Now the complication of the PCNL. First, the hemorrhage. It includes intraoperative and postoperative hemorrhage. First, the intraoperative hemorrhage. It occurs in approximately 1 to 35% of the cases, And the various factors associated are the surgical technique, experience of the surgeon, pre-op anemia, advanced age, increased size of the stone, need for the multiple threads, and intraoperative complications. To prevent this, proper pre-op workup is necessary. Antiplatelet medication must be discontinued as per the intraoperative risk. Proper operative technique should be followed. The proper technique is in prone to PCNL, posterior glacial puncture should be done in the direction of infundibulum, and thread direction should be only up to the peripheral aspect of the PCS. Thread should not be directed to medially to avoid pelvic tear and injury to hilar vessels. Thread and sheath size appear to be one of the strongest risk factors for the operative blood loss. Care must be taken to keep the working sheet in the collecting system. Excessive talking of the rigid instrument should be avoided. And in this place, we can use a flexible nephroscope or additional threads can be done. If excess and still we see bleeding in the system, first we have to check the position of the working sheet. If the end of the sheet has gone in parenchyma, we must reposition the sheet within the collection system. Even if it is filled, then we must put a large nephrostomy tube. If it again the bleeding is not controlled, we must clamp it for 2 to 3 hours. We can also give mannitol, which hastens the clotting by causing renal swelling within the capsule. That may cause temporary effect. If these maneuvers fail, especially nephrostomy tube that is the clotted, and even if the blood is bleeding in control, we must go for angiography and selective embolize. Use of fibrin glue is controversial. It is not found to be beneficial in meta-analysis. Also, there is some concern that injecting a fibrin glue, namely still into collection system, it may form a solid clot that may obstruct the collecting system. Now, the post-operative hemorrhage, only 1% of the patient requires invasive treatment. If bleeding occurs with the nephrostomy tube in situ, we must clamp it. If it is not controlled, then we must replace it with a specialized nephrostomy tube like K tube. If it is not contained, then the patient must undergo renal angiography with embolization. If clinical bleeding occurs after removal of nephrostomy tube, distal temperament must be done. If not controlled, we must replace it with a large nephrostomy tube under fluoroscopic guidance and clamp the nephrostomy. We must advise the patient for a bed rest, and blood transfusion should be given if needed. After that, selective embolization of the patient must be done if the condition applies. Now, the perinephric hemorrhage, it is suspected in the patient with a clear urine draining from the nephrostomy as well as from the Foley's catheter, but with decreasing hemoglobin, can occur in difficult cases with thin parenchyma. Now, the sandwich therapy, it includes PCNL followed by ESWL followed by second loop PCNL. A subcapsular or a perinephric hemorrhage caused by ESWL may be exacerbated by the further thread and collecting system manipulation. CECD should be done for evaluation in such cases. Management includes bed rest, hemoglobin monitoring, serial physical examination, imaging if needed, and blood transfusion SOS. What is delayed bleeding? It mainly occurs 1 to 3 weeks post-operatively. The risk factors are the solitary kidney, multiple stones, stagnant calculus, and the surgeon's inexperience. Most common etiologies are laceration of the segmental artery, arteriovenous malformation, arteriovenous fistula, and pseudoaneurysm. Angioembolization is the treatment of choice. If it is fails, then open exploration with vascular repair or nephrectomy may be done. Now, the second complication is collection system injuries. First is the perforation extravasation. It is suspected if perirenal or renal cell and sweat is visualized. Working sheet is located outside the system, resulting in large amount of extravasation, retroperitoneum, and abdominal cavity. It may prove to have a ventilation difficulty, hypovolemia, hemodynamic anomaly, post-operative. Even the micro PCNL or micropuck may cause significant increase in renal pelvic pressure, leading to perforation. What should be done? UAG or CT guided drainage if respiratory stress or prolonged ileus is present or infection suspected. If perforation occurs, immediately terminate the procedure and place a nephrostomy tube. Most perforation heal in 72 hours. However, it is prudent to wait for 1 week. Then a repeat nephrostomy must be done to confirm healing and then go for the completing the procedure. Now, the uterine avulsion, I have already discussed. Now, the extrauterine stone fragment migration or the lost stone. It is not of any clinical consequences unless the urine and the stone are not infected and the stone is far from the collecting system and ureter, not to cause any periuterine inflammation and subsequent stricture. Endoscopic retrieval should not be attempted as it may increase the size of the perforation. Stricture I have already discussed in the previous section. Now, the infundibular stenosis. Risk factors include prolonged operative duration, large stone burden, extended post-operative nephrostomy tube drainage. It is usually detected in the first year after PCNL. Management includes nephrostomy placement and eventual antegrade creation of neoinfundibular with laser. Now, the other complication is retained foreign body. A piece of the instrument used can be break off in the renal collecting system. Every effort should be made to find and remove the foreign body, as it may act as a nidus for stone formation or can cause granulomatous reaction in the kidney. The management include antegrade or retrograde removal with or without the use of fluoroscopic guidance. Now, the nephrocortex fistula, it is caused by the distal obstruction secondary to uteral edema, obstructing a stone, blood clot, or stricture. If delayed fistula is suspected, we have to suspect the genetic urinary tuberculosis. Management is relief of the distal obstruction, usually allowing the fistula to close. Injury resulting from the energy sources. Various lithotripter can cause energy, cause complications like ultrasonic lithotripter can cause injury to collection system or uteral perforation. When a probe is clogged with a debris, overheating may take place and a thermal injury may occur. When electrohydral perforation of the system and bleeding may occur. For combined there is small discomfort. When laser is used, there is perforation, bleeding, and thermal injury. Injury to adjacent structures. Lung intruder, these are the most structure which are at most risk. Percentage includes 0.3 to 15%. It includes pneumothorax, hydrothorax, hemothorax, and nephrocortex fistula. More common with the supracostal puncture. Routine intraop chest fluoroscopy is recommended at the termination of PCNL to evaluate for these complications. Routine checks is not required if results of the fluoroscopy are normal. Pre-op CT during expiratory and respiratory phase extraction in pre-op planning. And if this complication occurs, ICD should be placed. In case of nephrocortex fistula, it may be diagnosed on RGP. Management includes placement of an ICD.
From speaker, please make everyone mute. Please make everyone mute. Dr. Vikas Kumar, please make yourself mute.
Please mute yourself. Make everyone mute except speaker. I request everyone to please mute yourself. Those who are not presenting, please mute yourself. Vikas, please mute yourself.
Because please mute yourself.
Please mute yourself.
He's not listening actually.
Requesting everyone to mute yourself. Next time, Ranjan sir, the control will be with the office so that only the speaker can be unmuted.
I'm requesting Ruma and asking her to mute everyone, accepting.
Yes, please ask everyone to mute. We will raise hands to be unmuted. Yeah. Dr. Khare, you can start.
Yes, sir. So nephrocortex fistula, it is diagnosed on RGP. Management includes placement of an ICD with uteral stent or DJ stent with or without nephrostomy tube. Intercostal vessel injury during supracostal access may cause hemothorax, and for that, chest drainage should be done. For the prevention of this, access should be directly above the rib to avoid the intercostal vessel injury. Now, the second most injured perirenal structure is the colon. Retrorenal colon is found in 0.6% of the cases. High risk cases include horseshoe kidney and other renal fusel anomalies, renal ectopia, colon distension, probably due to the gastric bypass surgeries, neurological impairment, lower pole puncture, left side procedures, and previous chronic surgeries, older age and female sex. Pre-op CT should be done to rule out the retrorenal colon. Majority of the cases can be managed conservatively. Even if perforation occurs and it is retroperitoneal and there are no signs of peritonitis or sepsis, a uterine stent and a Foley's catheter should be placed, and we must pull back the nephrostomy back into the colon and along with the giving infusion of the broad spectrum antibiotics. And a repeat contrast studies it should be done at the 7 to 10 days through the nephrostomy tube. If there is no evidence of nephrocolifistula, we must remove the colostomy tube. Now, the other one is the small intestine. This is rare to see. However, it can second and third portion of the duodenum are since adjacent to the lower pole of the right kidney, they might get injured. If they are injured, the management is the surgical exploration. Liver, gallbladder, and spleen, they are really injured. They are injured when we put a supracostal or intercostal puncture, and these organs are at risk when there is hepatomegaly or splenomegaly. Medical complications, infection and sepsis. It is mandatory for all patients with UTI to be treated with appropriate antibiotics before PCNL. Antibiotic therapy for patients with UTI should be initiated at least 1 week before the procedure. Negative pre-urinary culture do not preclude patients from the developing bacteremia and urosepsis. Renal, pelvis, and stone culture should be sent during PCNL to predict and guide therapy in the event of urosepsis. If purulent urine is found during the procedure, we must immediately abandon the procedure. We must put an nephrostomy tube to drain the collector system, or we may place a resistant and a culture-specific antibiotic should be started. Sepsis may occur in the approximately 1 to 1.5% of cases. Aggressive management is required. It includes antibiotics with fluid resuscitation, with or without the use of vasopressor or steroids. Fungal urosepsis should be suspected in diabetic and immunocompromised patients. Fluid overload, collecting system perforation and bleeding increase the fluid absorption. Management includes lowest irrigation pressure that permits the visibility, use of the working sheet to reduce the PCS pressure, short operating time. We should abort the procedure in case of significant perforation. Normal saline should be used as an irrigant. Diuretics may be required for managing fluid overload. Hypothermia. When at body temperature decreases below 36 degrees Celsius, the causes are due to vasodilation, secondary anesthesia, length of the procedure, exposed body surface area, and a lower room temperature. It can be prevented by the warm irrigant, proper patient coverage, heat-preserving drape, and keeping the patient dry. Now, the position-related injuries, the ocular injuries, it may be happen due to ischemic optic neuropathy. Patient may have brachial plexus and other peripheral nerve injuries. If neuroplexus is suspected, prompt neurological evaluation should be done. Most of the injuries are managed conservatively. However, in case of obese and high-risk cases, supine PCNL should be done. Air embolism, when air is injected in the PCS to delineate the calcium anatomy, it may come into the system. Clinical features include hypertension, bradycardia, fall in end-tidal carbon dioxide, and cardiopulmonary arrest. Management includes immediate cessation of the procedure. We must place the patient in left lateral decubitus with a renal position. Patient should be closely monitored. Inotropic steroid may be needed, and hyperbaric oxygen should be given if cerebral involvement is seen. Deep vein thrombosis and pulmonary embolism, these are rare. DVT occurs in approximately 3% of cases. Prevention includes compressor stockings and sequential compression devices and early post-op ambulation. If DVT occurs, our main concern should be to prevent the propagation of thrombus, and anticoagulation should be done. However, there is risk of bleeding. Now, loss of renal function. Effect of PCNL or renal function is minimal. The patient with stage 1 stones are unique in their increased risk of renal function deterioration. However, the deterioration is due to the result of a stone disease rather than the surgery. Mortality is extremely rare. Myocardial infarction and pulmonary embolism may occur in the high-risk cases. Now, complication due to retrograde intrarenal surgery. It includes uterine mucosal injury during the placement of uterine access sheath. Patient may have bleeding, perforation, and extravasation, postoperative fever, and urosepsis. Now, complication due to endoscopic combined intrarenal surgeries. It may include the complications which were common to the URSL, RERS, as well as PCNL. Now, the complication due to periurethral cystosis, urethral stricture and mucous stenosis may occur because of the repeated passage of the transurethral instruments. Complication due to percutaneous cystosis, complication include wound infection, urine leak, and persistent hematuria. Now, complication due to cystosis, it may include bladder mucosal injury, bladder perforation, urethral stricture. Now, complication due to open renal stone surgery, these include mainly wound infections, bleeding, postoperative fever, loss of renal function, position-related complication, deep vein thrombosis, and pulmonary embolism. Now, complication due to open bladder stone surgery, cystotomy, it includes wound infection, persistent urinary leak, hematuria, and patient may have a need for prolonged catheterization. Thank you.
Dr. Ishansh, stop sharing your screen. It's a brilliant presentation. You are able to sum up everything, URS, PCNL, RIRS, and then open surgery. I congratulate you. It was a very comprehensive one. I did a good job.
Thank you.
A huge subject has been covered by you.
Yeah. Very good presentation.
Well done. Well done.
That time Yes, covered so many procedures.
Yeah.
Absolutely.
Senapati sir.
I have a question. Can I ask a question?
Yes, sir,
Yes,
please, sir. Please, sir.
Yes,
Yes.
Go
sir.
ahead, sir. Correct.
Did you actually present the complications of ESWL?
Yes, no, sir. So
No.
actually, my topic was the complication of surgery, so I didn't use that EHWL for that. I only did the surgery part of.
All right. So you
His
excluded.
topic was stone surgery. So I was amazed that I covered ECIRS and everything.
But it's important actually. The ESWL has many complications. So
Yes,
I think it's important.
it has. It has. I agree with you, sir. Our Senapati sir, should we move to the next presentation?
Yes, yes.
Anybody has any questions to the our three presenters, postgraduate students, Dr. Dipankar, Dr. Ankit, or Asanj?
Yes, you are the moderator, boss.
So any questions? Otherwise, we'll move to next presentation because we are doing very well. We are within time, so I will move to next speaker. If anybody has any question, they can raise their hand in between. We can take the question after the presentation. So I will invite my fellow colleague, Dr. Nitish Kumar, who is very, very enthusiastic about whole this thing, and I just prepared a very nice presentation. I've seen a part of it. So I invite Dr. Nitish to share his presentation, techniques of renal PCS access. Nitish, over to you.
Good evening, everyone, my seniors, the younger colleagues, and my colleagues. Today, I will be presenting the techniques of PCNL access. I will be presenting a video, so introduction might be said again. Just let me know if you hear. Is it audible?
Nitish, we're waiting a presentation to be seen. You are audible.
Sir, I've shared the screen.
Yeah. Just wait, give it a few moments, it will come. We see you, not your presentation.
Yeah, I've started. Colleagues or juniors and the students. Is it audible? Do things.
Nitish, but we don't see your PPT.
Experience.
Nitish, we
Yes,
are
sir.
not able to see your PPT.
I'm
Is it a
presenting a
recorded
video, sir.
Okay.
Yeah, I'm
go ahead.
presenting a video, sir, directly. Is it visible?
Show your video, not yourself.
Yeah, it is audible, but only your voice in the video is not audible.
Okay, sir. Sir, I will do a backup for the voice. I can get 10 seconds, sir.
Okay. We are right in time.
My seniors, colleagues, and the future colleagues. Today we have assembled to learn and share our experience. Is it audible now? And to teach the younger colleagues,
Yes.
juniors. Today we have assembled to learn and share our experience.
Your voice is not clear.
Teach the younger colleagues, juniors, and the students. Can you see the video? How to do things in a perfect way. I will be speaking on the techniques of renal access. Let's start. The techniques of renal access. You cannot finish until you start. So in PCNL, the initial puncture and tract is the first mandate for renal access. To disclaim, the video contents are taken from EAU educational videos, Dr. S.K. Paul and Dr. Sashikant Mishra. The supine puncture video is mine. Before going there, let's reconsider some basic anatomy of the kidney. We know that kidneys fall almost at a 30-degree from a horizontal plane, and they are almost at a 30-degree from a horizontal plane, this angle. The upper poles are more medial and they are more posterior. Most important thing in PCNL is the blood supply of the kidney, and most dreadful complication is bleeding. We know that kidney receives almost 1/4% of the blood. So our puncture should be clear cut so that we do not injure the major vessels. We know that the renal artery divides into 4 anterior segmental branches and 1 posterior segmental branches, and this is the segmental supply of the kidney. We are more interested in this line, the posterior avascular plane, the Brodell's line, which lies here almost at the direction of the posterior calyx, and we intend to make our punctures here. When we see the corrosion cast, the periphery of the kidney has less amount of blood supply. You can see here also the blood supply is less, or the abundance of the blood vessels is less. So we intend to go from there. Coming to the techniques proper, the most important technique which we'll be discussing is the fluoroscopic guided. Other techniques are the CT or ESC guided. ESC guided also will be discussed. In fluoroscopy, we use 3 techniques: the bullseye, triangulation, and the gradual descent. As we know that mostly in India and Asia, most of the access is made by urologists, but in US, only 20% of the urologists make their own tracks. Other are made by intervention radiologists. Before going there, let's understand the fluoroscopy and the relative movement. We see fluoroscopy in a 0-degree position of the CM and at 30-degree position of the CM. Whenever we are seeing a thing, we are seeing in a straight line. Suppose we are seeing this dot from here. If we move from here, the relative position will change. So let's consider this in a 30 degrees position. All these dots will fall on the same line. We'll see that everything is same. But when we move from 30 to 0, the targets which are superficial will move laterally, and the targets or the dots which were medial will move, which were deeper will move medial. Now here, you can see that whenever the 3 situations will be there, and the CM is moved from 30 degree to 0 degree, you can see the needle movement position is moving laterally. You can see the needle is moving laterally. It means that needle is superficial. Coming to the second scenario, again the CM is moved from 30 degree to 0 degree, and you can see that needle is moving medially. You can see the needle is moving medially. It means that you have gone deeper. You need to readjust your angle and come superficial. And this is the third scenario, in which again the CM is moved from 30 degree to 0 degree, and you can see the needle tip and the calyceal tip is almost lying at the same line. You may be slightly short. You need to go inside and will puncture the desired calyx. Eye of the needle, the bullseye technique. In this, the CM is placed first at the 30 degree position, and the needle is positioned so that the needle tip, the needle shaft, and the calyx are all inclined to the CM. Rotating the CM back to 0 degree position monitors the needle depth. This is the basic principle. You can see when the CM is rotated at 0 degree, the needle was laterally, so that it was a shallow puncture. So needle adjustments are made, it's pushed deeper. Now, the fluoroscopy with CM at 0 degree position will define our medial vertical plane for the entry to the calyx. After that, the CM is rotated 30 degree towards the surgeon, so that the axis of the CM falls in the same central posterior plane of the kidney, providing a direct entry into the posterior calyx. The axis needle is then advanced in the plane of the fluoroscopic beam with CM in 30 degree position, and using a hemostats is recommended to advance the needle 1 to 2 centimeter increments towards the desired calyx, and also to minimize the radiation exposure to the surgeon. The depth of the needle position is monitored by rotating the CM back on a vertical position. Now, with the CM back at 0 degree, the tip of the needle at predetermined calyx can be seen, and it's adjusted as needed. Urine reflex and the direct passage to guide wire will confirm that we have entered the culprit. In gradual descent, what is different from the bullseye that ends Instead of puncturing here, we are moving more laterally on the skin so that we are going more laterally on the more towards this avascular broadbase line. So we'll start from 20% of the, and this, the CM is placed first at a 30-degree position and the needle is positioned so that the slight glitch, 2 seconds. That is, instead of puncturing here, we are moving more laterally on the skin so that we are going more laterally on the more towards this avascular broadbase line. So we'll start from here and try to go gradually. So just a second, I will resume. Long axis. The image intensifier is set initially at 0 degree and this provides a perpendicular view of the needle. The image intensifier up to 30 degree by planar. Sorry for the glitch, we'll start again. The image intensifier is set initially at 0 degree and this provides a perpendicular view of the needle. The image intensifier is then repositioned at 30 degree towards the head for an oblique view. It can also be turned either towards feet or towards the surgeon's side. In this, there is a horseshoe technique and upper hole puncture will be made by moving the CM in a cephalic direction. The tip of the needle points to a posterior calyx which is filled with air. With CM at 0 degree, the needle is advanced into the patient. But at this point, we do not know whether the needle is above or below the calyx. The CM is then repositioned at 30 degree towards the head for an oblique view. And then it's moved in. Turning the needle back, turning the CM back at 0 degree confirms the appropriate position. And then a passage of guide wire is confirmatory. We can also do this confirmation of depth by turning the CM 30 degree towards the surgeon's hand or towards the feet. Now, a second puncture will be made in the same patient with the CM rotated downwards 30 degree towards the feet. And this, the CM arm is initially at 0 degree with needle pointing to the calyx. But again, the depth is not known. The CM is then rotated 30 degree towards the patient feet. And you can see the needle was almost at the tip. It was not moving in relation to the calyx. When the needle is in calyx in both 0 and 30 degree, it's confirmatory that it has gone inside. Further, the efflux of clear fluid and passage of guidewires confirms that the puncture has been made. Now, to show again the motion of the needle with relation to the CM, when the CM is turned towards the feet, then the needle will move towards the head. When the CM is turned towards the head, the needle, which is superficial, will move towards the feet. To vice versa, and the needle is more deeper. In this technique, we do not move our CM to any position, We do everything in a 0 degree position. We will come with experience. This was the 30-degree position of the CM. We start our puncture from here and we try to meet our target on a 0 degree on this line. So this is a monoplanar 2-dimensional fluoroscopic technique. In this technique, the CM is not rotated and the CM is placed at 0 degree. The plane of the calyx and its infundibulum is recognized with the needle set on the patient's skin. The first plane is actually defined, but the depth and the angle of the needle needed to reach the calyx is recognized by the surgeon's experience, and it's adjusted by changing the inclination of the needle as it's advanced towards the kidney. The needle is set on the patient's skin along the side of the infundibulum of the calyx so that all falls in line. Calyx, infundibulum, and the axis to the pelvis in a straight line. The skin is then incised. The needle is taken and is gradually advanced towards the kidney and the calyx. The movement of the kidney and the indentation of the calyx is sought for. If it is not satisfactory, it's readjusted and the movement of the needle to move the calyx and aspiration confirms the appropriate puncture. Triangulation technique, which has come before that gradual descent technique. Triangulation technique. The CM is positioned over the patient in a vertical 0 degree position and skin over the desired calyx is marked as a point A. This plane defines the medial extent of the needle penetration. The CM is then rotated at 30 degrees to the surgeon's side for an end-on view of the posterior calyx, and this point is marked as a point B on the skin. The skin over the desired calyx is marked lateral to the first side and creating an equilateral triangle, and this point will be the entry of the circle. Now, we assume this X as a point AB as a distance on the skin and the depth R as a radius of a circle, and AB will be the circumference. With this, we tend to calculate the R that will be desired depth. And from the third point, we try to move in a pyramid so that we meet the apex of the triangle of points A, B, and the third point. Coming to triangulation in clinical practice, in order to decrease the radiation to the surgeon, the CM is angled away from the line of puncture, with image intensifier angled towards the head of the patient. The CM is then moved back and forth between two positions, one that is parallel and one that is oblique to the line of puncture. With CM in parallel position, the adjustments are made in mediolateral direction, means from right to left. And with CM in oblique positions, adjustments are made in cephalopodal direction, means up and down. It is very crucial to make only one adjustment at a time and to respect the different orientation as they pertain to CM position. Now coming to a real case scenario, as soon as the proper orientation is obtained, the needle is advanced towards the target calyx with CM in oblique position. And before the renal capsule is penetrated, the position of the needle is checked with CM in parallel position. After proper positioning is confirmed, the needle is advanced into the calyx with CM back to the oblique position. And once the target calyx has been identified and confirmed by aspiration of the urine, the diagram is patched. So the multiple rotations will be moved back and forth from 0 degree to 30 degree to confirm whether we are entering a plane, and we try to hit the pyramid of all CM is at 0 degree, and again, for it to meet this point from here. So coming to the video, RGP means upper retrograde calculus, and now we'll mark a point on the skin or the target calyx, then we'll mark a point laterally on the skin, we'll make a stab, and then with the needle we'll go inside and we'll try to hit that target calyx. When we are going inside, we can make readjustments, and we see we are going inside, but the kidney is not moving. So let's see, the kidney is not moving, it is moving independently, so we are missing the target. We need to readjust. Either we have to go superficially or deeper. That will come with experience. In this case, I was much more superficial to the kidney. Now I have readjusted the needle, and then I have gone much slightly deeper. And now you can see that kidney is moving, and you can see the indentation of the calyx, and the needle has gone inside. After it has gone inside, the clear fluid is coming. You can pass the guide wire, and you are done with your puncture and access. This also comes with experience. USG guided puncture. And this we use a USG. This was made by Dr. Sasikant with pelvic stone. What we need for a USG guided puncture is attachment for the USG, in which we have attachment for the needle. And then it goes into that attachment, so that needle will be held tightly, it will not sway away, the direction will not change. And this attachment is attached to the USG probe, and then USG is turned from medial to lateral side. The kidney is seen, a target calyx is selected, and this needle guide will help you, will tell you the path of the needle. And then you select a point on the skin, make a stab. You put the needle, fix the needle in that needle fixator of that attachment, and then you go inside under direct vision or in the real-time view in a USG, and you try to hit the target calyx. You go deeper, deeper, deeper. Once you feel the loss of resistance, you come out, and the clear reflux of water says that you have gone inside the guide wire is placed, and these things are done. The question arises now, which technique to learn? The techniques you learn will change with experience. USI technique is the first technique which is taught because it's very easy to learn, and it's a sure throat technique. Later on, because there is a difficulty intrarenal manipulations or walking into the PCS because of the angulation and torque, one needs to change its position of the puncture. So one will learn the triangulation technique because the punctures are slightly lateral to that. One becomes master in triangulation, then he can gradually progress to gradual descent technique in a biplanar approach. As soon as he does a few number of cases, around 100 or maybe 50, depending on his expertise or experience, he can gradually shift to a monoplanar technique. This is the time when you can do a thing in a gradual descent monoplanar or even in biplanar. You can switch to supine PCA. Though we have discussed all the available techniques, but the thing is, you have to get trained in the way you are taught. And then you can start exploring the new avenues. When you come to your private practice or when you become a consultant, when you start doing the PCNS independently, wait till you master the techniques. The single technique you learn, master it. Get about 200 cases in your belt. And then you get the confidence that you can do the thing in your way if you fail. And then you can start the new avenues, exploring new avenues. Suppose you have get trained in USI technique or a triangulation technique, start doing cases in that. And once you are master in that, you can start your gradual descent technique, either biplanar or monoplanar. And the ultimate achievement is you can do a puncture within 10 seconds, 15 seconds, or 20 seconds, just monoplanar 0-degree view of the C-arm. And thus, if you can achieve that in prone, you can do supine PCNLs also. Thank you everyone for the patient listening. Best of luck.
Thank you, Nitesh, for a wonderful presentation. I think we have covered the topic exhaustively and very illustratively. You have shown us the pros and cons needed. I'm sure it will be very helpful to postgraduate students. And I'm sure there will be a lot of questions for you. I request everyone to put in the chat box so that we move on with the next talk. I will invite Professor Supriya Basu for the next talk, extended pulmonary. I know in today's era, after Nitish's presentation, extended pulmonary looks odd because now most of us are not doing open surgery for the Crohn's disease. So it's a very important topic and it's very difficult to get a video on this. Dr. Basu, on a very short notice, is able to compile it for the students, how to proceed in such a case, what incision should you give, how to approach the kidney, what are the planes. So I'm sure it will revise the memory of all the senior people, as well as it will help juniors to visualize how to approach a case of extended pulmonary. May I invite Professor Supriya Basu, please.
Basu sir, are you here? Professor Basu? Can you call him?
I'm just trying to call, sir.
Yeah.
Yeah, I'm just trying to call him.
But I saw him once. His name was shown once.
Yeah, I'll just call, sir. We are on the schedule, no problem. Okay. Yeah, sir is just preparing, making his laptop here for the presentation. So is there?
एजुकेशनल गेम है ही नहीं, इतनी घटिया सा गेम है। तो आपने लिया था खुद देखो देखो।
Something if you want that. I'm sorry for the mishap and there is some problem. So, however, I hope I'm audible. And in that case, my topic is extended parallel lithotomy. So, this is an age-old operation. Lots of urologists practice it. There is no doubt about that. And because in spite of that, this topic has been selected because this is an era of endourology, and in endourology,
Usually, especially the young urologists are very proficient. I cannot deny. And am I audible? Am I audible?
Yes, sir,
yes,
audible,
you are
very
audible,
clear.
sir.
Your presentation is looking good. We can see full screen. Go ahead, sir.
This is what?
Your presentation is seen clearly. You are audible, and we are listening to your narrative. Go ahead, sir.
Thank you. Now, it's because this is not practiced nowadays very often, and the young urologist may not be conversant with the procedure. Of course, I do not blame them because it is hardly done nowadays. And truly speaking, for all big stones, the different kinds of surgery has come up, especially the percutaneous nephrolithotomy, that is PCNL. And for that, this topic has been chosen, and it has been I am assigned to speak on that. That's fine. I accept the offer delightedly. And see, as because you have taken me back few decades back, and so let me take you to a few years more. You know, when this kind of big stones came across, the usual practice was to do a nephrolithotomy, put an incision in the kidney and take out the stone. But you can jolly well understand that this kind of big incision can cause massive bleeding. There may be massive leak, and of course, it can jeopardize the renal function. The bleeding may risk the life of the kidney or even life of the patient also. Now, understood that this is not a very good surgery, and it is associated with lots of complications. Now, let me show you this is the gentleman, and he is very famous. This is Gil Varnett, and he popularized the concept of approach for complex renal stones, the big renal stone. So he has got a good contribution for the stone surgery in urology, and he started to promote the concept of complex renal stone. Of course, we all do pyelolithotomy, but in spite of that, before I really embark upon the extended pyelolithotomy, which is an extension of the surgery, I think it will be prudent to go for the discussion few things about the renal hilar anatomy, as well as in the renal sinus approach for complex renal stones. Now you see that in 1939, Suraco, there is two kinds of renal sinus approach. Maybe it's an intracapsular approach or maybe extracapsular approach. But in intracapsular approach, the problem is this: there is a good amount of bleeding. The renal parenchyma, especially the lower pole, is injured, and it can be to go to this extent that so much so the lower polar segmental artery may be injured, and subsequently the surgeon may be forced to repair it or ligate it. Of course, you can jolly well understand that goes ultimately to some kind of renal infarction, and the GFR drops definitely. So that also could not become very popular. In 1951, Babix and Hellstrom, they advocated, they promoted, and they popularized the extracapsular approach for the renal sinus. And then they started to say that in that case, the injury to the lower pole, the chances of bleeding is less, the visibility is good, and it is very easy for the surgeon to reach the proper spot where the nephrotomy can be done to approach the stone. So this is the whole credit after that goes to Gil Varnett. You know, he has developed a new surgical concepts in removing renal calculi, especially the bigger one. Now, the main indication for this kind of surgery, that is the extended pyelolithotomy, the small stones can be easily taken out by the simple pyelolithotomy, but the pyelotome incision should be extended when there are big stones with a calycial branching. These are called staghorn stones, we all know. So that is good, and that should be practiced. And I advocate to my juniors that, of course, I know that you are proficient in endourological procedures, but at the same time, you must obtain your mastery on this open approach. And this is not only my advocating, this is, you can see that even in Eastern Association of Urology, Eastern Association, European Association of Urology, and even in the year 1922, 2022, so they advocated that this procedure can be tried in cases if there is a previous treatment failure or if there is an unlikely success with ESWL and or PCNL. So that needs a lot of good homework to find out, to select the proper cases when PCNL may not be suitable. So that is very important. And if there is a doubt in that cases, extended parallel lithotomy should be tried without any shame. Now, the initial, once again, I'm going back, and the initial pyelolithotomy was done in different kinds of lumbotomy incision. The initial oblique lumbotomy incision used to traverse all the layers, but they used to cut the muscle. And this muscle cutting causes lots of bleeding and poor vision, and the surgery becomes difficult. So it was very badly criticized at that point of time. And at that point of time, they used to exteriorize the kidney also. And that is also very difficult, technically difficult, and surgery becomes cumbersome. So this exteriorization of the kidney also became badly criticized, and it was not popular. So here comes the role of Dr. Day1, who has done a marvelous procedure. And here, as because we all know what is the position of the pyelolithotomy, so that kind of position is there. There, the head should be down below, and the leg and the superficial above the leg, it should be flexed at the hip and the knee, and the lower leg should be extended properly. And the table should be broken so that the space between the lowest most rib, 12th rib, and highest point of iliac crest can be increased. It is possible to go for a subcostal incision, but in most of the cases, we usually go for a transcostal incision through the 12th or 11th rib bed. Now, we can see here that this is the line of incision, and you can see that the first we can see that there are line of incision, and here this cursor is not working. What is the cursor? So basically, there are 3 layers of muscles, especially in the anteriorly. That is the external oblique, internal oblique, and transverse abdominis. But as the incision and extend towards the big back, towards the spines, there are other muscles which come across. So number 1, there is at the back, latissimus dorsi usually come across, and we'll have to cut it. And at times, so here this is the external oblique, and if necessary, in that case, if you come back, so it usually cut latissimus dorsi. Usually the serratus posterior inferior usually does not come in the incision line, but if it comes, there is no harm in splitting it and going deep. Internal obliques are usually situated into the anteriorly. It goes below, and its direction is downwards and medially. The transversus abdominis of the transverse muscle. So that also should be cut, and we can go to the pararenal space. So before we really go for that, you can see the last this picture here. There are some posterotransverse ligament. This is between the rib and the transverse process. And here it should be cut, especially in lumbotomy incision, but it does not come into the picture when there is a subcostal or transcostal approach. So that's how we go inside, and in the pararenal space is entered. Now you can see that this is the kidney exposed, and the beauty of this incision, lumbotomy, of course, gives especially the vertical lumbotomy, especially gives a direct view of the posterior aspect of the kidney, but this is no way inferior. Here also, suppose if we do a transcostal incision, and that will also give us or take us to the posterior aspect of the renal hilum. So this renal hilum we can see, and you can see there is a hilar pad of fat. So this hilar pad of fat is usually, this is the hilar pad of fat, and this is the scissors which is introduced to make a split in the renal hilar pad of fat. So that is the usual ideal technique for it. And as soon as it is, this space is developed, we can go for we can expose the whole kidney. So it can be facilitated by gauge dissection. That is also popularized in the name of Gil Barnett. We call it gauge dissection by Gil Barnett. He said it, and that can give rise a adequate view. You can see down below the picture. This is the pelvis and upper calyx, middle calyx, lower calyx. So in all these cases, the picture is so definite and so distinguished that the surgeon makes no problem to go for that. This is a pylocalycial incision. So if you see the first figure, I'm concentrating on the first figure only. If you see the first figure, so here there is an here. Now you can see the U-shaped incision. The limbs of the U, one is extended towards the upper calyx, the lower incision is extended to the inferior calyx. And here it should be borne in mind, especially, and this thing is also true for a simple pyelolithotomy also, that this incision should not go below the pujae. It should not cut across the pujae, because that can give rise to a stricture. So this incision should be in the pelvis, which has been exposed properly after splitting the hilar flat, and it can be extended into the upper calyx and lower calyx, and that way we can approach the stone. There are smaller incision, you can make it vertical, but once again I can emphasize that this vertical incision is not recommended for pyelolithotomy, or of course extended pyelolithotomy is out of question. This is a Gil Barnett retractor. Thus, you can jolly well see these are the instruments basically used for eyelid operations, for brain parenchyma retraction in neurosurgery, but it is very valuable as far as this hilar exposure is concerned, and you can split the fat, you can remove the fat from your field of vision, and you can introduce this oblique thing in a between the lip of the hilum and the pelvicalycial system as such. Here I can show you that there is one simple device, poor man's device of a hilar. This is a metallic. This is made of copper. The beauty of it is this is autoclavable, and at the same time you can modulate it. You can give it a different kind of shape according to the shape of the hilum, and that you can place it properly to the angle so that you can retract to expose the upper calyx and major calyx. And now, as because even today I said that this is an era of endourology, there are procedures. If previously it was not possible, but now our junior colleagues, they are more conversant with using these ancillary procedures. They can go for it, and that will definitely help for stone clearance. Number one, through this pylotomy, they can introduce a flexible cystoscope or nephroscope, and they can find out the stone. And at times, if necessary, it can be combined together with some kind of nephrolithotomy. Nephrolithotomy at times may be necessary for an impacted calycial stone or for mushroom stone. Mushroom stones, by that mean whose heads is ball-like and it gets impacted, or it is very difficult to take it out through the narrow infundibulum. In that cases, you can, without laceration in the infundibulum, if you do a small nephrotomy and take it out, there is no harm in it. And this incision should be put in the scarred area, which causes less bleeding. We all know that the stone induces the peripheral scarring. there may be some depression. It can be identified the scarred area through which we can put the nephrotomy incision and take out the head of the stone. And usually it is preferred by radial incision. Most of the urologists, they use radial incision because the vascular architecture runs along the curvature of the kidney. So there are other ancillary procedures also, that is vascular clamp, and we can use surface cooling. We are all aware of these procedures because we have seen some anatrophic nephrolithotomy. There is a coagulum pyelolithotomy. This is not very much practiced nowadays, and I don't have personal experience about that. And the Doppler ultrasound is also very good instrument, because if we use it during the surgery operatively, it can cause the identification. It can help us to identify the segmental arteries, and we can take care so that this is not injured. Now, once again, I say that the surgery should be done with a homework. You must identify the problems, anticipate the problems, and so in that cases, the proper case selection is mandatory for a better success. The previously extended pyelolithotomy is a contraindication for a repeat pyelolithotomy. In that case, we'll have to adopt some other measures. Extremely internal pelvis, if it goes high up or low below, so that is also very dangerous. And everything has got its own limitation. You can't extend the incision up to the upper pole or the lower pole. So those things should be adjudged first, maybe preoperatively through the figures, or paraoperatively by seeing whether it is going inside of the staghorn is too big or not. The staghorn calculi in clubbed calyx, by that I mean there is an infundibular stenosis and almost there is a dumbbell septic stones. So that is not good for extended pyelolithotomy. The complications by previous speakers, they all discussed different kinds of complications. The complications are really very similar. So in spite of that, just to name that it can be grouped in 3 groups: intraoperative, immediate postoperative, and late postoperative. Intraoperative hemorrhage, I said, and all this effort was done on behalf of the urologists to reduce the hemorrhage so that the renal functional capacity remains good, GFR remains good, and after the surgery, the patient's kidney works better. So, and the extension of incision, that is also a problem. If it is within the parenchyma, that's fine, that still can be covered. But once again, as the word of warning is that it should not come below, down the ureter, and up to the ureter, crossing the pujae. That can cause a stricture, and it may need a separate procedure afterwards if it causes outflow obstruction, urinary outflow obstruction. The residual stone fragments in minor calyces, they might be there. In today's world, of course, we take the help of ESW or something like that. But once again, I said there are ancillary procedures like cystoscopy, flexible, of course, and then we can take it out. So that is not the problem. Immediate postoperative complications, sepsis and leak, they can be drained properly. And the late postoperative fistula, that should, if there is a stain, this fistula should subside. And secondary pujae, that's what I have said, I have emphasized, it can occur only if you injure the pelvic junction. Now there are lots of papers, once again, let me put it this way, that don't think this is an obsolete procedure. You cannot shrug it off. It has its good place, and even European Association of Urology recommended it even in this year, 2022. So there is a definite place of extended pyelolithotomy. It's called Gilbert separation, and for staghorn calculi. Now see there's a Boyes and Elkins. They said the more extensive procedure of anatrophic nephrolithotomy appears to have no advantages over the Gilbert operation. So if we are really take our attention, do the meticulous dissection, go through the hilum, everything, and the extension, then it will produce very comparable result. And there is no reason to think that anatrophic nephrolithotomy is superior to it. At this point of time, you might think that I'm contesting a debate. defending the extended palatal. No. I'm not defending anything. Everything has its own place. Only one thing what I want to emphasize, that it has got its own role, its own place as far as the stone management is concerned. Extended palatal is an article by Withrow and Wickham. Extended palatal usually improves impaired renal function, and some patients may be saved from dialysis. Very good point, very big point, because if the stone always impairs the renal function, if we can save the patient for subsequent dialysis, that's a good job done. Usually in their report of the Woodhouse, there is no nephrectomy, there is no mortality. So these all goes in favor of extended palatal. Regrowth of stone is not inevitable. They have gone to the extent that even a tiny stone, if it is left with, don't think that will give rise to a regrowth of stone. So that not even, and the renal function usually improves. So especially if you compare it with other big surgeries like anatrophic nephrolithotomy and all, the renal function is considerably low. Those are the other slides. It has been proved. I'm coming to that. Like this is extended palatal and versus anatrophic nephrolithotomy. Renal function, in most of the cases, it is improves. But in anatrophic nephrolithotomy, as such, the renal function is compromised by the stone burden. And after that, such a massive Brodels line incision, it deteriorates on again, and the renal function improves very rarely. Blood loss in extended palatal is minimal because we are not putting an incision in the renal parenchyma, but in anatrophic, it is a considerable. Result is comparable and good. Extended palatal, the use of renal artery clamping and regional hypothermia. I said these are the ancillary procedures which can give rise to good vision. But once again, here is the word of caution, and I must say, for all practical purpose, try to avoid renal clamping because it has got its own demerits. So that is not a very desirable option, but you can try it. If necessary, you can try it. Robotic extended palatal in today's world, everybody is trying robotics. I don't have any personal experience with robots, and there are literature supports the view. It is coming up in the different modern literatures. The robotic extended palatal appears to be safe and effective. So that is another. This is an approach by Badani. I'm proud, and it's by Mani Menon also. I'm proud the Indians are producing such good results with such modern procedures. These robotic extended palatal is a cosmetic replica. Naturally, there is only ports and there is not a good scar. So the person goes back to the work very fast if you do the robotic extended palatal. But everything, whatever you do, that glorifies the extended palatal. And I must say that you can't forget extended palatal just like that. So this is another article by Stolio. Robotic extended palatal for complex staghorn calculus. Here they have given few interesting suggestions and few interesting data that they have said success rate in PCNL is around 78%, and with open surgery it is 71%. So this is quite comparable. But at the same time, I must say they are brave enough and honest enough that never try to hide the fact that there are reports on the contrary also. The open surgery patent stone-free rate for complex renal stone in randomized control trial 66% and 49%. 66% there is a better renal stone clearance, and PCNL it is 49%. So that once again goes in favor of extended palatal setup. This is another data. This is a randomized control trial. Lots of reports have been conglomerated, and they have said here they have shown that this PCNL is basically data has been collected and challenged by PCNL with the extended palatal. Of course, PCNL has got its own advantage, but you can see that the intraoperative complications and post-operative complications, everything is comparable, and extended palatal is no way inferior. The main thing is that if you see the stone-free rate, even as far as the percentage is concerned, it is better in open. However, it is not statistically significant. Now, let me conclude this. In this area of endourology, extended pathway has its own place, and especially if other procedures are difficult, when you apprehend complications with that, you can jolly well try it. And extended palliative produces comparable results and occasionally with better stone clearance. Thank you. Thank you very much.
Excellent presentation, Basu sir.
Excellent presentation, Professor Basu.
Thank you. Thank you, sir.
Very precise, Dr. Basu. Very well prepared in a very short span of time. You have really done a great job.
Endourology, and you have presented the age-old procedure with demonstration of chill Burnett retractor and all this is very nice.
Thank you, sir.
Can you stop sharing your screen, sir?
Should I? What should I do?
Just stop sharing.
Okay, okay.
Since we are well within the time, we're just 3 minutes beyond time. So we have time for MCQs. If there are no any further questions, I will invite Dr. Nitesh to start the MCQs. And then I will present subsequent MCQs.
Just click on stop sharing.
Yeah, I'll do it. I'll do it. I'm doing it.
Nitesh, in the meantime, you please ready with your.
Yes, I'm ready with that. Sir, stop. I will start sharing, sir.
Yeah.
Is it okay now?
Okay, okay.
Fine.
Okay.
Nitesh, be on time. I have some questions. You
Okay,
finished
sir.
first yours. So, are the postgraduate students are there?
Yes, sir.
Yes, sir. Keep yourself unmuted so that you all can answer and we can move on fast. Nitesh will also be discussing the answers also. Go ahead, Nitesh, start.
Okay. Shall I start? This is the 26 years male, has a calculus of 24 mm, 10 mm, 5 mm in the right kidney, and a urinary bladder calculus also. He had a pyelolithotomy at 14 years of age and PCNL at 20 years. Is a history of multiple stone passages. So the first question, what should be done next? Arrange in order.
Loud, please. Anybody can answer.
Sir, the option B, stone removal and then the stone analysis.
Okay, so option B first, then?
So then option A, metabolic
Okay.
evaluation. Then then it's the dietary modification. Then specific stone related treatment.
Okay, so we have to proceed like this. The first we have to remove the stone and then go for analysis, and detailed evaluation will be proceeded later. So the easy one already discussed. So we'll move on to the next. Which among these are not associated with high risk of stone formation? Early onset of urolithiasis, brucite containing stones, increased levels of vitamin D, and solitary kidney.
Solitary kidney?
Yeah.
No, solitary
Yeah.
kidney is also associated with high stone.
Actually, you can see the EU guidelines. The solitary kidney does not itself particularly increase the risk of stone formation, but the prevention of stone recurrence is more important. So they are considered in a category of high risk formers, but they are not associated actually with the increased risk. Coming to the third question, all are indications for metabolic stone evaluation except first, solitary kidney, anatomical abnormalities, calcium oxalate stones, and renal insufficiency.
Renal insufficiency.
Calcium oxalate stones?
No, calcium, oh, correct. Because in renal insufficiency, you need to prevent any further stone formation and there will be multiple metabolic abnormalities. In calcium oxalate stones does not require any kind of metabolic stone evaluation. The next question, all are included in abbreviated evaluation of single stone formation, single stone, and abbreviated evaluation,
Urine
except
cystine.
urine.
Urine cystine. Urine cystine.
No.
Urine
Anyone else?
oxalate. Urine
Yeah.
oxalate.
Yeah, urine oxalate. Urine cystine. I will discuss the details of the answers later, the explanation. Come to the fifth question. All are included in blood screening of stone patients except
Magnesium.
Magnesium.
Okay, correct.
So magnesium.
So we can see the abbreviated evaluation of single stones. In basic metabolic panel, magnesium is not included. Sodium, potassium, chloride, blood urea, nitrogen, creatinine, calcium, PTH, and uric acid is included. And you can see in urine, qualitative cystine is always included in single stone forms. This is according to the Campbell's. Coming to the next question, see the image and tell where has the guide wire gone.
Retroperitoneum.
Anyone else?
IVC. IVC.
Yes.
The right side of the screen is the feet and left side is the head of the patient. Can you see the ribs behind the guide wire?
Yes, sir. Yes, sir.
So anyone, any other guess?
IVC.
Pleura.
Actually, this is a dreadful, very dreadful complication. This guide wire can enter even a smaller renal venule, and it can easily follow the course of renal vein, and straight away it will go into the IVC. So in this case, it has gone into the IVC. So the case posted by someone else. So I've taken the picture. It has gone into IVC, and almost it has entered into the or reached the heart. So during puncture, anytime if your guide wire is crossing midline, always be aware that it has gone in a vessel, or it will start an upward course. Any upward course, be aware. Do not go inside, or just pull out your needle and do a fresh puncture. Question 7. When is the ideal time to assess for colon injury? During puncture, during dilatation, during exit, and post-operative period?
During dilatation?
During puncture, sir.
Puncture.
Yeah. So how do we assess whether you have entered the colon or not during puncture?
The gas shadow will be seen.
Colon will move.
Shadow is seen before puncture and during puncture. You can see in the image.
So you can aspirate.
It will move.
Colon will move.
Yeah. Both colon and kidneys will move with your respiration. So you have to see the relative movement. When your needle is inside, the kidney will be almost fixed because of the fulcrum effect at the skin. And if you hold the needle, it will be relatively less mobile. If the colonic saddles are moving independently of the kidney, it means that you are not inside the colon. So adjustment should be made always during the puncture, and you have to be very cautious about this gas shadow. Your one eye should be at the tip of the papilla or the calyx you want to puncture, and another eye, when the needle is traversing, should be focusing on any movement of that gas shadow. They will also indent, and like you do a air pilogram and puncture the calyces, it will see indentation and the movement will be obliterated. I will hand over to Dr. Harpreet, sir.
You, Nitish. Nitish, have you stopped sharing?
Yes, I have stopped, sir, already.
Can you see my screen?
Yes, sir.
Yeah. So I think Dr. Basu has very nicely covered it. The first question comes for extended parallel lithotomy. All are true except A. Bloodless vein lies between connective tissue of renal sinus and pelvis. B. Also known as a Jill Walnut vein. C. Incision is given vertically. D. Incision can be extended to calyces vertically along the calyces axis. You have to find out which is false, which is untrue in this.
So the incision is given usually
Given by
But
vertical.
C.
Correct.
Dr. C is
Incision has always have to be transverse along the axis of the pelvis, because if you give a vertical incision, there is a possibility of causing a UPJ obstruction because of scarring and fibrosis. So the incision always transverse along the plane of pelvis, and vertically you can extend it along the. That's a very well said. Good. Now coming to some questions about pregnancy, which Ankit has covered very well. All are complications of pregnancy except obstructive uropathy, hypertension, higher incidence of cesarean section, gestational diabetes mellitus, recurrent abortion, preeclampsia, and myocardial infarction.
The higher incidence of cesarean section.
Cesarean section.
Is a complication of pregnancy? No. Higher incidence is no. Pregnancy, more and more people don't go for normal labor because there are preterm labors.
myocardial infarction.
Myocardial infarction, sir.
Yes. I just put you to confuse it that you always don't think of cardiac arrest every time. As such, they are directly related A to F. Okay. So what percentage of hydronephrosis on left side you see in pregnancy? 20%, 30%, 10%, 15%. A, B, C, D.
10%.
Sir.
No.
20%, sir.
10%, sir. It is less, sir. Yes, sir.
It is 33%. Almost to the tune of 30%. So on the right side, almost 90%, but on the left side, on the 67%. So why left ureter is protected in pregnancy, or why there is less hydronephrosis? All are true except the left ureter is distal and medial because of sigmoid colon, or the left ureter is proximal and lateral. What anatomy? Which one?
A, distal and medial, sir.
Okay, good. So you're right, left ureter is protected because it is more proximal and lateral and sigmoid colon preventing. Whereas the right side, it is on the pelvic brim and the dextral rotation of the uterus, so it's more prone for hydronephrosis. What type of stones are seen in pregnancy?
Calcium phosphate.
Phosphate.
Calcium phosphate.
Wow. Why?
Calcium phosphate. Because of the increased pH, urine pH is increased and
कौन बोल रहा है? अंकित बोल रहा है?
Yes,
अंकित तो present किया हुआ है. Okay, good. So this is also, see, I have seen this all being presented. So it's a very easy one. We just want to see you have listened to it. Somebody is presenting it when a friend is presenting. What is the sensitivity and specificity for diagnosis of urinary stone by ultrasound in pregnancy? Ankit, you will not. It is for others, Dipankar and all others, all postgraduate students.
The B42.
Sir,
B42
sensitivity is 42% and specificity 68%. Answer B, sir.
Actually, this is exact line was there in the Ankit's presentation. It's A, 34% sensitivity and 86% specificity. So ultrasound is a first modality. It is a very good modality you can use in all the types, but sensitivity becomes less because of the dilatation. Effect of radiation exposure classified as stochastic or deterministic. And you have to match the right answer. What does the word stochastic means, or what does the deterministic mean? You have to match one in the below given. A, dose dependent above a baseline threshold dose. B, at any level of radiation exposure. See, you have a radiation exposure. So, and there are two words used for this. Any takers?
Stochastic is any level of radiation exposure.
Pardon?
Stochastic means radiation effect at any level of radiation exposure.
Yes, correct. So stochastic means, because see, we say that this certain amount of radiation will not harm fetus. But still we are not very sure about it because this is some metabolic malignancies may take place. So at any level, where is the deterministic, the dose dependent? I'm having a next question to it. No association between radiation dose and fetal anomalies or pregnancy loss. Less than 5 rads, 5 to 10 rads, 10 to 15 rads, more than 15 rads.
Less than 5 rads.
Yes, less than 5 rads, generally speaking, but still, what here comes the word statistic. We say that it's a dose dependent, which is deterministic, but some amount of which we still don't know. As the reason why there is so much debate whether to use CT scan in the pregnancy or not. But can you tell me how much in last 2 decades, how much, which percentage of CT scan, how much percent of CT scan use has been increased in pregnancy? Any guess? Wild guess?
Increased by more than 70% of CT use in overall urological.
What are you telling? How much?
So more than 70% there has been increment in use of
I'm talking on pregnancy.
Pregnancy.
In pregnancy, in last few decades, we have seen it's a more almost to the tune of 25%. The CT scan has been used in pregnant ladies. So this is much the increase. 5 to 10 rats we see is a it's a equivocal. We don't know whether it will affect or not, but more than 10 definitely it affects the intellectual functions. MRU can be done from which trimester of pregnancy? First, second, third. MRU कौन से ट्राइमेस्टर से कर सकते हैं?
First trimester we can do, but advised from second trimester onwards.
MRU can be done from first trimester itself. Don't use gadolinium. Use it without contrast. It is safe in first trimester. When your ultrasound is equivocal, you can go and do the MRU without contrast, without gadolinium. This is a multipara lady, and she has a severe pain and has total counts are raised, creatinine 1.3, and urine culture E. coli. She have one multiple calculus and left lower gastric calculus 9 mm, and interted single live fetus 12 weeks and 2 days. What should be the best approach? Admit and IV antibiotics, oral antibiotics, DJ stent, PCA.
So admit and
IV antibiotics along with DJ stents.
Okay. But her counts are very high. There's obstructed system. Don't you think?
Admit and IV, sir.
And sir, DJ stenting can be done, sir, along with.
Yeah, see, it's a little debatable point, but what I want to tell you that it's a PCN is a very good option in such patients. You can do and just straight away the ultrasound, and it acts both decompress the system as well as the stone passes on its own after you because of dilatation. So this was done in this patient. But yes, you start with IV antibiotics and you watch it, and it is not responding to it. All are true for fluoroscopic etiquette except high dose and continuous fluoroscopy. Dead shielding of the patient pelvis can reduce total radiation exposure. Positioning of CM image source below patient and image coning to include only the renal area. Endoscopically visualized or ultrasound guided passage of the ureteroscope may allow a completely radiation-free method of ureteroscopy in the gravid patient.
So option A, high dose and continuous.
High dose and fluoroscopy.
So what you will use in that case?
Pulse fluoroscopy.
Pulse.
Yes. Low dose and pulse. Thank you very much. So happy that you are able to answer almost 70 to 80%, almost I'd say 90% question answers. Over to sir.
Good evening. Excellent session, Dr. Harpreet. And I also thank our students and the other participants for their presentation, participation actively in this session. We are waiting for tomorrow's session, which will be hopefully much more interesting, and hope more students and more delegates and the more participants will participate to make our effort successful. And we'll be extremely happy if the students are happy and they are benefited by it. Once again, I am thanking Dr. Harpreet, Professor Supriya Basu, Dr. Nitesh, and everyone, those who have presented today and make this session extremely useful for the students. Over to Dr. Kalyan Sarkar for the conclusion of the sessions today. And Sarkar, are you here?
Yes, excellent session. I think I've got nothing to add to what Ranjan said. Let us hope that tomorrow's session is equally interesting and equally stimulating. And I think I enjoyed the session and learned as much as all of the students did. So wonderfully conducted.
Thank you.
Thank everyone.
I want to hear from the students what is their reaction on today's class and what their suggestion if they want to improve the session any further in the coming days. Any of the students, if they want.
Session was very, so session was very good, and we are quite benefited by this session. Thank you very much, sir. Thank you.
Thank you.
Ranjan sir, I think all this presentation should come to you, and East Zone can compile this presentation and hand over to all the postgraduate students.
This will be what is my planning. This will be kept in our website for future also, and at the same time we are making QR. We'll be making QR code of all the sessions in so that they can be utilized whenever they feel it, even without going to the computer and going to the website. But for that, we'll have to wait till the entire program is over. Then I will prepare and hand it over to the students and for the future students also.
Anybody, any thoughts, Rahul? Any senior person, Rajesh sir, or anybody wants to make any comment?
No, it was very nicely done. I think this is the beginning. My take on this is that it will take some time for us to refine, for both the partners to see what they want and what we should give it to them. So I think this is a very good beginning, and I really appreciate Ranjan boss and you also doing a good job. Let's see how it ends tomorrow. I think we should take a feedback form, and then we'll have that idea what next, because this is an ongoing process. This is not the first and the last time this is going to happen. So I think it is very important it is all student oriented. So we should take a definitive feedback from them with a questionnaire or a monkey survey, some sort of thing. Ranjan boss can always plan with what like I attend a lot of endourology, the online program hota hai. In that you can suggest the topics to them or something like that. Roundtable discussion. I attended one very good roundtable discussion among consultants, and a lot of people joined that and put the questions in the chat box. So this is an ongoing process, but a very good beginning. All the best. All the best.
Thank you. Thank you very much, Rahul. And all the way from the Jammu, you have participated, you have enlightened, and you have encouraged us and also the students for this. Thank you very much.
Thank you.
Thanks for having me.
Thank you, everybody. Good night. So nice. Thanks, fellow colleagues and all students and everybody who joined this session. See you tomorrow at 10.
Good. Okay.
Thank you.
Good night.
Bye. Bye. See you tomorrow morning.
See you tomorrow.
Bye. Bye.